Hello and welcome to this discussion session of the small-scale PPP program of the United Nations Economic Commission for Europe and the World Association of PPP Units and Professionals. We are delighted to have you with us. This is, as many of you know, this is a year-long program that looks at all aspects of small-scale PPPs and how to implement them, how to overcome some of the difficulties that are associated with them. And this program will end at the October or November this year, where there will be some guidelines that will be published by UNECE and WAP to that effect. So we started this program back in January. We started out by looking at defining small-scale PPPs. We then looked at what are some of the hurdles, what are some of the potential solutions that we can find to make the small-scale PPPs happen. We then looked at some of the legal impediments, some of the financing solutions that can be had. We looked at case studies from various countries during 3 sessions. And then we looked at some of the issues that are related more in the terms of financing and structuring. And we started then looking at sectoral aspects of small-scale PPPs. The last session we had was about water and wastewater. And today, this session is kicking off the social infrastructure string of sectoral studies for small-scale PPPs. We are going to talk about healthcare, and then next we're going to be talking about education and other matters. So if you haven't seen our full schedule, please, you can log on to our website, wap.net, and you will find the schedule there for next sessions. For today, this session is dedicated to offering a comprehensive understanding of the specific challenges and opportunities that small-scale PPPs present in the healthcare sector. By sharing practical experiences and exploring replicable and scalable strategies, we aim to provide actionable insights that can enhance the effectiveness and sustainability of healthcare PPPs. This session seeks to inspire new approaches to delivering high-quality healthcare services through small-scale partnerships, contributing to better health outcomes and more resilient healthcare systems. I'm delighted to have with us as moderator today, Mr. Nasser Masoud, who is the head of Concept Realization Advisors. This is the advisory firm that he has been heading for many years now, and that specializes in social infrastructure PPPs. Nasser also is the chair of the social infrastructure chapter within WAP. So Nasser, delighted to have you with us. I think both people in this session and future sessions are going to be able to benefit greatly from your experience. I turn it over to you for moderating this session and introducing the panelists. Thank you, everyone.
Thank you so much, Ziad, for this very kind introduction. Hi, everyone. Welcome to this webinar. I'm Nasser, and it's great to be here. Just really to put things in context, providing effective healthcare services is really essential for sustainable development. And we see this, of course, across the board with social sector, whether it's infrastructure or services or a combination of both. And in particular, when it comes to small-scale PPPs, our view, those who've practiced in the field of the social sector, will see that a lot of them actually feature as small-scale PPPs. In today's session, and I'm really delighted to have such an amazing set of panelists with us, we're going to dive deeper into the nuances of small-scale PPPs as they relate to the health sector. And of course, what we're trying to do here is to share our experiences so that we can provide scalable and replicable ideas for PPP units that are working in healthcare and similar sectors. and hopefully you'll get the opportunity to to hear the various insights from the panelists in terms of their experiences and what they have to say. So as we go through, we'll be hearing the challenges that they faced in the health sector and how they managed to make their initiatives work. And towards the end of the session, we're going to have a more interactive question and answer section with all the presenters on there. So please save your questions, and by all means, you can use the chat or the Q&A that is provided in Zoom. So allow me to extend a warm invitation to all attendees as well, to have so many of you on today. When we get to the end, we look at the questions and hopefully look to address them. So without further ado, let me start by first of all welcoming Mr. Arun Kumar, our first speaker. Arun is an investment and strategy professional with more than 2 decades of experience in high-impact private investments, valued at multi-billions of dollars. His focus is on developing markets. He previously was focusing on India, but now as a member of the African Development Bank, his focus is more on Africa. He manages private investments in the health sector at AFPB. Arun holds an undergraduate degree in electrical engineering and has an MBA. He's a certified investment appraisal and project finance expert as well. So welcome, Arun. I'm going to ask Arun, first of all, a couple of questions, and then I'm going to introduce the other panelists. Arun, DFIs tend to lean more towards the large infrastructure PPPs. We kind of see that in some of them. What's the line taken up by your organization, AFDB, on this? Or is there more of a strategy to structure health PPP projects as small-scale PPPs?
Thank you, Nasser. Thank you. Thank you so much for this opportunity. Very good morning and good afternoon to everyone for joining this session. Nasser, I think the healthcare is one of the very strategic focus for African Development Bank. I think some of the people who don't know about African Development Bank, African Development Bank is a multilateral development financial institution whose mandate is to invest into Africa. So we do all investments across sectors, high impact investments. You talk about energy, transport, agri, industry, health, education, job for youth, women-driven businesses also. So as a development bank, we do about $6 to $7 billion every year investment. So our prime objective is to look at how we can serve the society. That's the prime objective. And there is a very strong recommendation from the management that we have to see investment in a way how we can de-risk the transactions, de-risk the sector, how we can include all the stakeholders into the discussion. So coming back to the question on how we are looking at a small scale or the healthcare sector and in such. So we have a strategy called Strategy for Healthcare Infrastructure in Africa. And our objective is to invest into primary, secondary, tertiary diagnostic centers, and ICT and job employment is cross-cutting area in that. Our objective is to invest $3 billion till 2030. That's our objective, what we are looking at. And in terms of the size, small scale, yes, I think sometimes it's become very, very difficult to integrate these small scale projects. But I think the question we need to see that what is the problem we are solving? And we look at how we interact. I think that's a very interesting thing, how we work with the ecosystem. So there are different ways we work. The first way is that we prepare a country strategy paper. Every country in Africa, we prepare a 4-year plan, which talks about which are the sectors we have to invest in and what are the intervention with other stakeholders as well, including government, and what are the issues we are facing out of. So the one of the key thing what we see is that there is a capacity building issue at the public sector level and the private sector level. And that's where we bring different instrument or different initiative we have to strengthen the government policy dialogue with the government and stakeholders, and then also boost the investment environment. That's on the policy side. The second point is that we support the private sector projects, not only on the mainstream financing, but also provide grant for the projects to do the feasibility study. And that includes small scale also. But I think somewhere we have to draw a line depending upon the country, that what is the minimum size we look at. Normally we look at $20 million project. And if there is a market, we are talking about fragile state or low income country, then that the threshold of the project can also come down. So we work on in coordination. Now, the last point I would like to focus is that some of the projects where we are not able to come as a main lender, but what we do is that we share those opportunities and discuss with other development partners who provide support for these small scale projects. So it's a more of an ecosystem support. As a bank, we are doing it. That's our broad mandate. Nasser.
Thank you. That's really very insightful. And 30 billion by 2030 is a nice target.
It's 3 billion. It's 3 billion.
Okay, 3 billion. Okay, I was gonna say 3 billion. Okay, that's still quite a formidable number to achieve, especially in healthcare.
Nasir, there is a one rider here. When you're talking about 3 billion, meaning that our investment would be 3 billion. And
right.
Our policy doesn't allow us to invest more than 1/3 of the total. So that means the 3 billion will mobilize additional 6 billion. So we are talking about 9 billion.
Wow. That's that leveraging makes it even more, and I can imagine the impact will be very significant with that. Thank you very much. I want to move on to our next panelist and introduce Dhaval, Dr. Dhaval Jam. This time from another continent, from the Asian Development Bank. Dhaval is a principal market development advisory specialist at the Office of Market Advisory and PPPs at Asian Development Bank. And he leads the health sector PPP transaction advisory services at the bank, with over 20 years of experience, including 14 of those actually advising on social infrastructure. Has spent a lot of time with DFIs, having worked previously with IFC, International Finance Corporation, for about 12 years. In fact, first time Dhaval and I spoke, we wondered how we never crossed paths before. Dhaval is a doctor by training, and he practiced medicine for about 5 years before pursuing an MBA. And he has a dual major in finance and operations. So Dhaval, I want to welcome, of course, and I want to ask you the same question in terms of the trend to lean more towards large infrastructure PPPs. I'm aware, of course, that ADB spearheaded in Kazakhstan the Karaganda hospital project, but also from my experience, you've been looking at some other things that are smaller scale. So perhaps you can tell us about Asian Development Bank's strategy in that respect.
Thanks, Nasser, for the introduction. Hello to everyone, and thanks for inviting me here, and hello to all the attendees too. I'm Dhaval from Asian Development Bank. Briefly about the bank, the Asian Development Bank is one of the multilateral institutions, 68 members. We are member countries where we serve, and coming to your question, Nasser, about what ADB's stand is out there. So ADB's role is threefold, if I may put it. One is to invest or provide funding to governments to invest in public infrastructure and services, which is the mainstay and the larger piece of what ADB does. The second support is financing private sector entities, and again, which have a development impact and which includes a large portfolio in the health sector. Other than that, we have some technical assistance and support systems to our DMCs. And one, we are a climate bank, and we really want to focus and align ourselves with Paris alignment. But the team which I comes from is another niche team, which is from the PPP Transaction Advisory team, and we support various government entities on implementing PPP projects. Coming to the strategy for social sector project, we have a very long-term view, especially when it comes to PPPs and the PPPs that we support, is that the view is we have to see what is the end result of the PPP. The purpose of a health facility, according to us, is to provide service to an end beneficiary, to provide a public service. And so when we look at a PPP, we look more from that perspective. And in fact, we are very happy and keen to support governments on small PPPs or even zero capex PPPs if the end benefit to patients or community is high. There is no real clear definition of small scale PPPs. Some people associate it with size, but I like what WAP has defined it as a small component of how much is the transaction advisory become a component of a capex. And I'd also like to include O&M PPPs. They are very complex and it takes a lot of time to prepare them. And the capex from the private sector might be zero, but still it involves a lot of service elements, and ADB is very happy to support even those kind of projects, because we see, as I said, we want to see that the clinical outputs are really fine and can be quantified there. So in summary, our view is that we are not too focused on the size of the project from that perspective. And that's why while we work on both infrastructure PPPs, service delivery PPPs, integrated PPPs in the health sector, large scale, small scale, but there's one element or one lens that we apply is it improving the clinical outcome or not? And keeping that in mind, we are not really working towards any particular size in the project. It can be a $2 million project, it can be a $2 billion project. We really support that. So that's our view about supporting PPPs here with regard to size.
That's really useful to know. Thank you very much, Taval. I'll move to our next speaker, Gazmir Vahbi from Albania. Gazmir has a bachelor's in law and a master's in finance, and is very well versed in PPPs. He's spent 15 years within government administration, working on the private sector side and overseeing PPP projects at all stages. He was formerly the director of the PPP unit in Albania, and of course spearheaded some very important PPP projects in there, some of which of course we're going to be discussing in today's panel. And that really brought him a lot of expertise within the social sector. Gazmir also has the APMG certified public-private partnership expert qualification. So Gazi, I want to ask you about one of the projects that IFC is always talking about, which is the laboratories project in Albania, which kind of falls in the category of a support service or a specialized healthcare service. And we see now a lot of these now being rolled out in various countries, in particular radiology and laboratories to kind of deal with imaging and pathology. How can these, in your view, be effectively integrated into small-scale PPPs? And what do you see the key factors are that contribute to their success and to their sustainability?
Thank you, Nasser, for your introduction. Good evening and good morning, everyone. I'd like to thank you very much for this opportunity. Of course, yes, it's true that we had a very successful, let's say, project in. We had a lot of projects in healthcare system in Albania. We had, let's say, 4 of them, but One of the most successful one, and which is very good example as a small scale PVP, of course. It is the laboratories, national laboratories, let's say transformation, because they were already functioning, but from the public side, and then we jump to the PPP. I mean, we solicited the service to the private sector. This project is not a very big one, let's say, also for Albania, because you know that Albania is not a huge country. The investment value is almost 2 or 3 million, let's say. But the project value is about 16 or 80 million for the 10 years period. I think that this project has this brought a lot of value because of the IFC and the World Bank, which were assisting since the beginning of the project, since the identification and all the process with paperwork, and then also IFC was engaged to monitor the project. So it was a huge help on us. I was in the government sector in that side, so I was in charge to touch this project from the beginning to the end until the signing of the contract. So uh, it consists of 18 state laboratories, and the most innovative thing is that from 60 or 80 lab tests that were done at that time in the public sector laboratory system. Now it was doubled. It was almost 164 tests. So it's not bad uh, for the uh, for the hospitals, because the main beneficiary was the hospital. And I can say that the first uh, service was delivered to the inpatients and then to the outpatients. So we had uh, uh, 6 or 7 pathologies, which start with clinical chemistry, hematology, and cytopathology, which is the most important thing now, because all the diseases coming from that part, and the people are struggling with uh, uh, with this part, and also microbiology, immunology, and the genetic molecular diagnosis. This is the project. This is the scope of project. Uh, we can say that the labs were already upgraded to a very high level of certification, because before it was not very accurate. I mean, the ISOs and whatever certification needed for the equipment. The equipment were already new. I mean, 2017, that was the year of the project. So I think this will bring a very accuracy to the test. Also, some tests that were not possible to be done before in a shorter way and in a shorter time, that's now were already possible. So, but of course it's still a small scale PPP, because there was not much. It was not an integrated system. It was just the lab tests and that's it. So this is what I can say for this project. It's up to you, Nasser, if you have any other.
No, that's great. And I think, I mean, just building on what you're saying with what Dr. Deval said earlier, I think at the end of the day, it's what is the problem we're trying to solve? What is it that we're looking really to achieve in this? And in a way, the capex should not be the key driver to the success of the project or not. The key thing is whether the people get the service that they need. And I mean, there are many papers have been written now and research done on the impact of lab testing on the accuracy of course, the accuracy of diagnosis, which then leads to the overall health bill. And if you get those lab tests wrong, you're going to spend a lot of money, waste a lot of money rather, on treat patients compared to the other way around. So, and when you consider that actually the cost of investing in a lab or in proper imaging facilities that give you the right results, and we'll come on to talk about digitization as well with artificial intelligence that is being used to support these kind of services. Not only will it reduce cost, but it will give patients a much better experience, because if you get the diagnosis right first time, then the opportunity for treatment is so much faster. So thank you so much for insights, Ghazi. And last but not least, Dr. Varun, our next panelist, Varun Goyal. So Dr. Varun is a health economist. He has over a decade of experience in public-private partnerships. He's worked in defining capacity of facilities, done research to evaluate the impact of PPPs and so on. And Varun is really much more now into the digital side of healthcare. I know he has a real passion for that. He's developed various PPP solutions for different projects with both clinical and non-clinical services. And his work, although he has a lot of focus in India, but he's worked on projects in Europe, in Central Europe, in Asia, like Kazakhstan and Uzbekistan and so on, and currently in Africa and the Middle East. So Varun, I want to ask you a question really drawing on your experience in India. If you can highlight how strategic purchasing and creation of model contracts and documents for local administration have contributed to kind of successful implementation of projects, and in particular how we can draw that into PPPs, and in particular into small-scale PPPs.
Okay, thank you, Nasser, and thank you, Bob, for this opportunity to talk about healthcare small-scale PPPs. If we talk about India, basically, I wear a hat of both as a researcher and as a doing transactions, so I can talk about on both the sides. India, over the period of last 10 to 15 years, we have seen a graph that started with basic kind of small scale PPPs. So here we are talking about two kinds. One is strategic purchasing, which is kind of a private sector engagement. Another is kind of a PPP engagement. So I'll start with PPP first. So 10 years back, we started in India projects related to small scale PPPs, like doing laboratory PPPs or imaging PPPs, but in piecemeal. We didn't have at that time a national strategy to basically engage private sector for such projects. And at that time, India piloted a few hospital sector PPPs, whether brownfield or greenfield, but with very limited success, because we didn't have any model documents, we didn't have any guidance. All that we had is PPPs in non-health sector, in infrastructure sector. But then 10 years back, we understood that healthcare PPPs are very different from like transport PPP or any other kind of PPP, because it's a large mix of services and it is also related to the social part of it. So I think from 2014 onwards, Government of India understood that situation. They started creating, we had a PPP cell in Department of Economic Affairs. They started creating the greenfield green books or the model concession agreements for different kind of facilities, whether it is a brownfield or greenfield hospital, medical college, or a primary healthcare setting, or a diagnostic center. And they also created green books for the PPP practitioners, so that they can use what to do when doing such kind of PPPs. So states can take care of it at the subnational level and then use these model documents. Then what happened in 2015, when we had under the National Health Mission, that is Ministry of Health and Family Welfare, we had free diagnostic service initiative. So under that initiative, we basically started creating certain model documents defining the number of test types, laboratory as well as imaging, required by different type of facilities, whether it is a district hospital, sub-district hospital, community health center or a primary health center. So what is the minimum number of tests required by different facilities? Then slowly after that, national level government, they started giving instruction to the states that, okay, we are giving you certain guidance. Now you can start engaging the private sector for delivery of these lab services in your facilities. And then various states, they started engaging the private sector. They started taking the help of transaction advisor, or they by themselves, they started doing these transactions using these model documents. And from that time and now, we had around 50% of the states. We have total 36 states and union territories. So right now, 17 states, they have some kind of PPP in laboratory and imaging, right? And they are using these model documents guidance from the national level, and then doing these transactions at the state level. And over a period of time, what we have seen is these number of tests have increased from, let's say, as Ghazi mentioned, in India also it has increased from 63 tests to 235 tests now. And then states, they have built their capacity to do the vertical bundling. So they have started doing hub and spokes model within the district, and they have started combining the district hospital up to the PHC. So now a person sitting at a patient coming at the PHC can go for a high-end test under these kind of models. And then the type of models also get matured with time. We have now 3 or 4 different kind of PPP models in laboratory, which we can talk later. But then what we have seen is that these model documents really help. Another sector is the medical college PPPs, where we initially started. Medical college PPP history in India is very long. We recently had a study from Niti Aayog, which tells that the medical college PPPs date back to like 50 or 60 years back in India. But these PPPs, they were being done initially as part of the social component, and slowly they become part of the now in India after Niti Aayog, which is a think tank under the ministry under the Prime Minister. We have started, they have built a model concession agreement for medical college PPPs, where they are upgrading our district hospitals and attaching them with the medical college and giving it to the private sector on a concession agreement. So that also has come up very well, and now many states, they have started doing medical college PPPs to generate more of human resource for doctors and specialists. So that is another sector where we have seen increase. In addition to that, at the subnational level, we also have health PPP policies. We have, for example, in Uttar Pradesh, one of the largest state in India, we have health PPP policies, guidelines, model documents available to do different kind of PPPs, whether it is dialysis hospitals or like a 100-bed hospital or any other kind of infrastructure. So there also we have this. Now, if we talk about strategic purchasing, definitely we right now in India we have Pradhan Mantri Jan Arogya Yojana, one of the largest strategic purchasing scheme, which is totally subsidized, which is totally funded by the government, where we are giving around close to 6,000 plus benefit to the population, and we are covering around 100 million families under that, and that is totally funded by government, and people are using it for secondary and tertiary care services across all the public and private empaneled facilities across India. And it is being managed through a structured way of we are having a separate entity called National Health Authority. Then we have under the National Health Authority, you have State Health Authority. So it's a structured mechanism to implement this scheme with the use of a lot of digital health component, which we will talk about in this webinar, how digital health has supported PPP, or as a PPP increase the access to the services. And in addition to this, we have also other examples of strategic purchasing, like we have strategic purchasing for like Chiranjeevi scheme in Gujarat, where one of the state we procured the cesarean section, the deliveries for pregnant women through the private sector. We also have strategic purchasing in tuberculosis and HIV, where we are purchasing services from the diagnostic centers and from the doctors for identification of TB and HIV patient as well as for their diagnosis. So I think in this last 10 to 15 years, India has emerged as a strong advocate for small-scale PPPs.
Yeah, yeah, and these, I mean, I'm glad you kind of went in that direction, because I think that's another way of involving the private sector that is often forgotten. So absolutely, PPPs, which usually involve long-term commitments with definitive, pretty much wholesale offtake agreements of the services or of the availability in the case of infrastructure, is certainly one way to go. But I think what you described there, in terms of what we would call private sector participation, actually strategically buying services where there is no capacity in the government, or there's limited capacity. And we're seeing that actually in more and more places. And these are good examples of involving the private sector, essentially piggybacking on investments that they've already made and supplementing the existing capacity. So thank you so much for those insights, Varun. Okay, so from Varun, we're going to go back to Arun and to Africa. And I want to ask you about your experiences in Africa and the unique challenges that you have faced in structuring and delivering small-scale healthcare PPPs in this region. I think you already drew on some challenges like government capacity, human resources, and so on. But if you can kind of put that more in context, so things like, you know, where there is a piece of infrastructure that's being contemplated to be built, you know, what are the challenges with actually, you know, as the point you and others made, of realizing the benefits of this in the end, if those other structures aren't. So over to you, please, Arun.
Thank you, Nasir. And it's a great learning for me also, you know, hearing from other panelists, I think, from other regions. So on Nasir, on the healthcare side, or especially on small scale in Africa, most of the projects you classify in healthcare sector would be small scale. If I leave aside some of the public sector investments, but most of the project would fall under around $50 million bracket. Now, one of the critical challenge on the ecosystem, let's talk about the ecosystem, then we'll go at a transaction specific. I think the regulatory aspect is one of the challenge because of the lack of government capacity in terms of, you know, assessing these projects and their role in terms of boosting the investment. I think that's one big challenge where bank work with the stakeholders, government agencies, you know, all the regulatory Ministry of Health, and also we integrate Ministry of Education. So we look at a healthcare project not as a healthcare project, but as an education project as well, because you have to retain the healthcare professionals. So how do you manage them? This is one of the biggest challenge. You will find a lot of projects are built, but then there is a brain drain. A lot of healthcare professionals flying out of Africa. That's one challenge. Now, second challenge is affordability. You know, there are, you know, if I give you a broad number of outbound medical tourism, I think Nigeria itself is spend about $1 billion on outbound medical tourism. And then the question about how you can provide an affordable and quality healthcare service in the region is one of the challenges. So that's the role of the government, again, comes in insurance companies. If you look at a healthcare insurance in Africa, it's very expensive, but still there are a lot of things to be done on that side. Now, when I look at the transaction specific, the most of these transactions we look at, these transactions are kind of not prepared well enough. And that's one of the biggest challenge that, you know, COVID has created the urgency that we have to build healthcare facilities. But the question is how we need to do the full assessment, comprehensive assessment. I was looking for a question that the PPP, the civil society and NGOs are not included. So what we do is that when we do a feasibility study or we ask the client to do that, the project will be operated in an ecosystem. That means that the project has to be discussed with the Ministry of Health, Education, civil society, even the competition as well. It is very, very important that you bring all those things. I'll give you an example. I was speaking in West Africa conference on Africa Union a couple of weeks back. There was one of the sponsors was saying that in one of the country, the hospital occupancy is 20%. Now, one of the reason was that because the projects are designed in a way that is not helping the society. There are a lot of people are having healthcare issues, but they are not able to come in. Either there is an issue about, what kind of a different services you are providing. That's one thing. Second thing, integration with the ecosystem, because you cannot provide all the services. You have to work with the ecosystem, right? Primary, secondary, referral system, tertiary, diagnostic. That's another issue. Third thing is affordability. If there is no integration in the ecosystem, then the affordability cannot come because the business doesn't make sense. And that's the challenge we are having. And the bank, whenever we interact with, one of the qualifying criteria for a project is that it has to support the whole society. Low income, middle income, even some of the free. What is your strategy to address or support the vulnerable part of the society? That has to be there. Learning, development, awareness program. These are very, very important. So I think these are the challenges we have. But I think the COVID has created this, and that's where we support on all these initiatives in affordability aspect, feasibility study, we provide grant. We look at hybrid solutions. We look at other players to work with us in terms of providing some concessional or grant resources. Another biggest issue is the forex. Because if you're working in a project in Africa, then the revenue is in local currency. And the challenge, if you have a US dollar loan or euro loan, then that currency is depreciating about 10-15% every year. That's a big challenge. And now I think international global situations, what are happening on the Fed pricing and all those things are having a severe impact on the projects. So that's why local resource mobilization is another key where, let me come back to again, 1/3 of that. We provide 1/3 of capital and we ensure and bring the local partners into the play through the bank support, maybe some sort of a credit enhancement product. Through local bank, we provide guarantee to the local banks that the local bank can provide local currency and we can back the local bank in case of any default. So these are the broad challenges I would see. And another last point I would like to focus is that the out-of-pocket expense is at the highest right now, because the government capability of investing into healthcare has decreased because of the macroeconomic situations, and their share of investment is going down. So these are the things when we look at, and as Dhaval mentioned, that when we look at a project, we have to see the problem and what we are to achieve. And that's where what are the role of each and every player, not only in the planning stage or operation stage, but for a 10 to 15-year cycle. Thank you.
That's really tremendous. I really liked what you said about looking out for the entire ecosystem to make sure that the whole thing is actually going to work. And it's quite shocking when you think that in Africa, where there is a lot of healthcare need, that you find a hospital with only 20% occupancy, because all those other aspects have not really been brought into the picture. And I wonder, actually, I want to move on to Dr. Dhaval. I want to kind of open up the subject of digital solutions, and because they can be a way for creating that kind of ecosystem. One of the things that I always come to my mind in Africa, for example, how the mobile telephony overtook the banking system in terms of transfers and so on. And how, of course, mobile telephony in the first place took over landlines, and people just didn't go down the natural progression we saw in the developed countries, where you went for landlines and then went for mobiles. And whether potentially the digital solutions can be another trigger for all of this. So the question to you, Deval, if you can share some examples where digital solutions have been successfully integrated into these projects, and what kind of service delivery enhancement and patient outcome improvement there has been as a result, and of course, if you can mention some of the challenges with that along the way.
So thanks, Nasser. So yeah, digital solutions. I mean, these days we can't escape anything digital. You know, even when we look at ourselves, we have something digital embedded on our body almost all part of the day. So similarly, in when it comes to PPPs, large or small, digital does become part of it. In health sector in particular, there are nuances. I mean, we all talk about telemedicine, teleradiology. You know, we come out there and there have been some successful uh, cases where they have been implemented well, and the scope is tremendous. I mean, we spoke about AI also coming in and supporting. And the power of digital, the way it goes, is that in future, it not only would it help doctors in reaching faster diagnosis or treatment solutions, it is also it will have the capacity to tackle a bit of the shortage of manpower in health sector. For example, triage nurses can go one notch above, again in diagnostics and everything before they assign a patient to a particular specialty. That's just one small example, and that can be achieved through digital solutions. So overall, for health sector, digital solutions do provide. I mean, the sky is the limit out there, and as we move ahead, PPP or not PPP, digital will be a very integral part of any healthcare delivery going forward. In PPP, we can have very discrete solutions. As I've mentioned, there are HMIS and standard outsourcing. I would not typically call it a PPP. That's just outsourcing a service, but a PPP where some service is being delivered and there is a clinical outcome. Again, the most common ones, telemedicine, teleradiology. But for PPPs, before I go to that, another aspect where digital can be used is for training and teaching. For example, we're speaking about diagnostics, and I remember a project in India where we worked in imaging centers for, in medical colleges. And while for medical legal reasons, the test would be performed, imaging tests will be performed by technicians under the private partner. But the images and the reports were available on workstation, simulation station, for students to learn and to see complex cases and we'll get more and more out there. And it was not only good database, but a good way of learning. For PPPs, there's another very unique use of digital is monitoring of PPPs. All of us working in PPPs do know that these are long and complex PPP contracts, multi-year contracts, and a very critical part of a PPP contract is monitoring. And most of the countries that we work in, the developing countries, there is a lack of capability with the governments to monitor these PPP contracts well. So digital solution, and especially in healthcare, which can give some outcomes, in terms of from clinical outcomes. For example, dialysis. It's so simple that dialysis machine throws out or has the ability to throw out the result of dialysis by certain parameters. There's something called a URR or a KT/V, and from that, it can be judged whether the dialysis was done properly or not. And so that's just one example. There are other things also which, other monitoring reports and, dashboards which can be used by the government to monitor PPP contracts. So digital definitely there. The challenge for digital is the pace at which technology is advancing. The change in the required, the requisite regulation is not matching pace. And it's not, I mean, we have seen it in fintech, and the countries have now, I mean, globally, all countries, the developed ones have been forced to now work into regulations regarding fintech and how money matters. But the same thing is required in health sector. And once there are more clear regulations around it, especially medical legal aspects, for example, again, in many countries, prescribing of medicine to a digital solution is illegal. It's not allowed until the doctor and the patient have sat in front of each other. So, those kind of regulatory reforms are required to, involve more and more digital solutions out there. There are privacy laws to be taken care of and all. So I think I see that as a challenge, but I think it's a recognized challenge, and all governments are working towards it. And once there are one or two good examples, then adoption of those reforms, the regulations would be, I think it would spread. Nasser, if I may just take 1 minute more, and I would like to add to the questions that you asked Arun about the challenges of small scale PPPs. And, Arun did mention everything. I just wanted to add one small problem that we face as transaction advisors is when we are advising the government to procure, small, private partner, then for small scale PPPs, the private partner also tends to be a smallish company. And when it comes to small companies, they are not really, they do not have the governance systems, that you would see in a very large company. So when it comes to procurement, for example, when you ask for audited financial statements, a small SME might not have, an audited financial statement. So how do you actually assess the capability of the private partner there? So that is another challenge I would like to put in the mix. And so PPPs, small scale PPPs, poses that additional challenge in even procurement of private sector, how to select the right partner for a particular project. It's health sector, matter of life. So you have to be very careful, both from the financial and especially from the clinical point of view. Thanks, Nasser.
No, thank you so much, and thanks for that last point. And I particularly liked when you talked about the digital solutions, also for training and for leveraging staff capacity, because one of the big, I mean, it's a fact that there is a shortage of healthcare professionals worldwide, and the brain drain makes that even more imbalanced when it comes to the lower LMICs, lower middle income countries. I want to build on that particular point. I'll come back to that. I just want to ask Ghazi and Varun a couple of questions, but I want to come back and ask the panelists how they see solutions to this issue of the need perhaps to involve the smaller companies that don't have the balance sheets and the full credentials that a traditional PPP requires. Because it's one thing to say we're going to go small scale, and it's another thing to say, well, how does the rule book then get adapted to small scale? And I think you're hitting on a very key issue when it comes to small scale. I wanted to ask Ghazi a question about capacity in the public sector, because of course in developing the projects that you developed, I suppose one of the key things in the back of your minds was, if you were to do this as public sector investment, or maybe with some grant or soft loan money as a government initiative, whether it's labs or something else, would there be the capacity, and how can you compare capacity in the public sector with the private sector? Just really wanted to get your insights into that, because that's one of the things that kind of determines which path you take.
Yeah, of course, this is a very important issue. Of course, when it comes to the public health, is very sensitive, because the health sector is more sensitive than all the other sectors about the capacities. Sometimes we know that we have a lack of expertise in the ministries for preparing project and also for monitoring it. So, and of course, for the operation, which is the most important part, and we sometimes or let's say we always keep it in the government side. So we do not provide the operational part to the private sector because we feel more comfortable and we feel more safe when the service the service is in the hands of the public. We have an example with laboratories, as I mentioned, with the laboratories project, as I mentioned before, that in that case, the lab employees were going to be, let's say, out of the government contract or government protection because of the whole system or the whole lab system was going to be transferred to the private partner. In this case, we took a very we took an action and we put in the contract we put some clauses which were set for the beneficiary of employees and for the reason not to leave the public sector to find some other alternatives. So this example was very successful because we engaged in a contract that in first 3 years that no employees will be transferred or will be left without a contract, a proposal from the private company that's going to be operating the facility. And then we managed to put in the contract some clauses that the salaries of the employees of the government, which are going to be transferred to the private, are going to be matched with the private sector. So because we know that sometimes they have differences between public sector and the private sector salaries. And then they're going to be trained from the experts from the private side. So every to the support, and because I'm going to come back again to the support of the IFC for the preparation and for monitoring of the contract. Was very useful because the IFC continued to stay in the support of the government for preparing to the negotiation, also the signing of the contract, but also after the contract, we had the support of the expertise from the IFC for monitoring, which is the most important process for me in this case, because you have to be very careful when you monitor such contracts. So this was my insight about this project.
Thank you for that. And yes, the last point you made about monitoring is really quite vital. And I think those of us who have actually worked on monitoring PPP contracts will realize what value that brings and what value can be eroded from a very carefully drafted PPP agreement with KPIs and everything. And then at the end, if you're not monitoring, you may not achieve any of those positive results that you're looking for. Okay, Varun, I have a question for you on diagnostics. I know you've been working on some PPP projects in the diagnostics space, and whether small-scale PPPs in healthcare actually address the need for advanced diagnostics, particularly in areas that are underserved. And perhaps you can tell us about the projects you're doing in Ghana and elsewhere about this.
Yeah. So what we have seen in like how we can improve the access to the advanced diagnostics for the underserved population is what we have seen in India, and I'll also talk about other countries. What we have seen in India is that the states. So there are two types of model the states have tried. One was that they basically outsourced or contracted out the advanced test diagnostic at the district hospital level, at the higher level. So that was the reason they were getting less number of samples, because we recently conducted a study of laboratory and imaging PPP in India across 6 or 7 states. And we have found that the states where they have contracted out it at the higher level of facilities, most of these samples, if you see the contribution of samples, 70% of your samples are usually in the basic test category in case of PPP, and your 20% and then 10%, they are into the mid-advanced and high advanced level of test. So if you are not catering to, if you are not getting the volumes for this particular category, then it's not a viable PPP when you are doing the operations. So now the states, they have learned from this, and they have started expanding it to the lower level of facilities, the PHC and CHC level of facilities. So they are using a hub and spoke model, and they are doing a very good supply chain mechanism where they are sending their people to the ground level to collect the samples and then do the report generation through laboratory information management system. And then that way they are providing access to the advanced diagnostics at the lower level of facilities. What we have seen in Ghana, recently we evaluated what they are doing in terms of imaging diagnostic for the low and high end test. What we have seen in the lower category of facilities, they are able to serve population for, let's say, X-rays, ultrasound, and those minimum level of test. But when we talk about CT scans, MRIs, they are being placed at the regional hospital or at the medical college level. So definitely there is the people are not having access to the higher end services. But in that case, I think the teleradiology services could be one of the option for them, where they can be given access to at least to the district hospital level, where they have a good volume. The CT scan kind of services can be given, and the reporting can be done from the regional level or at the medical college level. So due to the deficiency of the radiologist at the lower level of facilities. And so these are some kind of examples we have seen where there is an increased access to the advanced diagnostic using different models and private sector is using their innovative models to in their PPP models, so that they have like a good demand for the test volumes also, so that for them it's an affordable project at the end.
Cool, thank you for that. It's gone at half past 5, at least in Dubai, so 3:30, and we have about half an hour to go. I think before coming back to some questions that we've prepared for the panelists, I wanted to pick up on some of the things that the audience participants have posted. And I can see a question about somehow, I think you've already answered one there, Arun, on will it work in an NGO or civil society? And I think the answer you offered was how you would reach out to create this ecosystem and look at different participants. I wonder if Deval perhaps can give a perspective on that, if that's something that you've had experience in, particularly whether in IFC or currently in ADB.
The thing about PPPs is that these are contractual obligations, and a PPP typically involves penalties on entities if they do not meet certain KPIs. When it comes to NGOs, or any civil society organizations, they are doing it not with the motive of any profiteering. And so from their perspective, putting a penalty in that sort of a scenario where the work is charitable, it becomes a real big challenge in structuring those contracts. So the PPP contracts, which you see with the with NGOs particularly, they lack that particular element of contractual monitoring, penalties, those that we respect the KPIs and all. Because again, the way NGOs are structured becomes very difficult to run there. Having said that, I mean, I would not really call every partnership as a PPP, but there are many successful areas where NGOs have partnered with governments and have provided and helped provide services out there. But again, as I said, in a pure typical PPP format, following a very strict PPP contractual arrangement is something which is not something that we've seen being successful out there. So that's something from a transaction advisory perspective.
Thanks. And I see Varun has his hand up. Perhaps you'd like to comment on that.
Yeah. Yes. So a little bit on how the civil society organizations, they have been engaged in PPP projects. What we have seen is, as Dhaval rightly mentioned, not as specifically in terms of typical PPP, but like O&M contracts for running the primary health centers or the community health centers. PPPs, the civil society organizations have been procured by the government. And also one of the area where they are playing a good role is in TB and tuberculosis and HIV, where they act as patient provider interface agencies or patient provider support agencies, where government or development partners, they release their fund to them, and then they subcontract the local civil society organizations to work with the local private facilities to basically do the strategic purchasing for either for the diagnosis or for providing the treatment to the TB patients or the HIV patients. And in that case, it's a very robust monitoring mechanism they follow, and they define when they do the subcontracting, they define a lot of indicators, and a single penny cannot go to the subcontractor if they are not working as per the performance indicators. So I think that's a very good model where the whole payment is based on the to the subcontractors in the based on these performance indicators, and then and it basically handles provide a good amount of patient care, and they are tracking across the whole care cascade. Yeah, thank you.
Okay, thanks. I'm just looking at another question from somebody anonymous. Oh no, it's actually a question from Wilson Godalo. Do we have successful PPP examples in healthcare sector, like modern hospitals or hospital clinics, without any initial public subsidy? One of the topics I wanted to open up was actually about hybrid financing and co-financing. So perhaps we can look at an answer in that context. Before we go there, I think because we want to talk more about small-scale PPPs. I mean, to answer your question, Wilson, there are many examples of successful healthcare PPPs, depending on how you define success. So, in the developed world, in the UK, in Canada, Australia, France, a lot of Western Europe, there have been a lot of infrastructure-type health PPP projects. Which were aimed at building capacity. The clinical operations were, of course, done by the public sector. Those were considered successful because they achieved that objective. Some of the issues that came out of it was the potential to have created overcapacity because of the way the projects were configured and the health master planning around them and so on. But if we kind of turn our attention more to small-scale PPPs, I think we see particularly in the NMICs many successful smaller projects. Dialysis is a good case in point. I think radiology and so on, but also we're seeing more and more coming up in areas of primary healthcare and the like. Bringing it back to your question in terms of initial public subsidy, I think one of the things to bear in mind with social sector generally is that this is typically a public sector obligation. I mean, that's what distinguishes the social sector from other sectors. And therefore, there's the expectation that people are not going to pay out of their pocket for the service. So whether it features as a public subsidy in the context of a hybrid financing, or in the context of an uptake agreement where the government is actually paying for the service on behalf of the patient, or at least contributing significantly towards that with some kind of a co-payment, there will always be an element of that. But I want to ask Arun and then Dhaval to tell us about the role of hybrid financing in these types of projects, and then perhaps Ghazi also can comment from his previous work.
Nasir, thank you. Nasir, I think the hybrid component is very critical for social sector. As I mentioned to you, is that the kind of in-depth analysis we need as a transaction for any transactions, it required some resources. I think that the hybrid structure starts from there on the project preparation side. At a bank, we have about 35 or 40 trust funds. These trust funds are designed to support low income, middle income, and high income countries, depending on the sectors we have and the intervention we could have. So some of the interventions start from providing technical assistance to the government as well as the private sector. So that's the first point of bringing hybrid. And how we can boost the environment in terms of reform discussion, policy dialogue. There also, we found out that the government also needs some sort of a, if you are providing some capital to the government, and technical assistance is part of that, is always about 10 to 15%. So that's another. Now we work with other development financial institutions, ISDB, IFC, World Bank in different sectors, and in healthcare as well. So they also come up with their package, in terms of loan as well as the grant. Now, the second piece is that what I have seen recently is that there is a lot of movement of private investments where the donors are coming with a different capital stake. One would be a grant capital or a philanthropy capital or donor capital, and the next would be more of a commercial or DFI capital. And these instruments, you will find out that one of the fund, I know that there is a Transform Healthcare Fund where there was a capital stack of 65-35, and there the grant capital is utilized for building small projects, supporting those small projects wherever it is possible, doing the comprehensive assessment and optimization strategy. So that capital is utilized for building those projects and providing growth capital. So that's another model sort of projects we have seen in the healthcare, and most of these are small scale. Now in PPP, because bear in mind, in Africa, healthcare PPPs are very unique. There is the contractual obligations are on O&M side, you'll find that. Or maybe some of the supplying of vaccines or medicines or something very relevant, very specific. But if you're talking about healthcare infra, in terms of where you build a hospital and then you provide, different healthcare services to the society, there the contractual obligations are very limited. Some of the projects are there, but those are public sector driven projects. Their private sector might play a role, very small role, but overall that is not the case. But what we are seeing right now, I'm actually working in Nigeria on the 2 public PPPs where the government has gone through a comprehensive procurement process. And now government is providing land or some sort of additional support, not beyond that. And the government is saying, okay, now you build a project and serve the society. So those kind of models are more prevailing in Africa. Thank you.
Great, thanks. Move to Dhaval.
Hi, actually, Nasir, the question about financing for PPPs, I was thinking of what to answer and how to go about it, but I think I can go on for about a couple of hours talking about it, of how different financial structures can help. In short, yes, for healthcare PPPs as such, as a matter of fact, any other sector PPPs, any subsidy coming from the government would reduce the risk of capital that the private sector investor would see out there. And also keeping in mind, as I said, it's not an easy question. I mean, there are different countries and there are different country credit ratings. So a sovereign guarantee of a payment or a termination payment coming from a high credit worthy country makes the investment more secure. But when you're talking about low credit rating countries, then it becomes a bit difficult to get that security to investors and their lenders. So either you increase more securities, increase the cost of capital for doing that, but the government subsidy coming in, it lowers the capex, lowers the overall absolute risk that is investment risk that the private partner or the lender is facing. So it does help. But to answer Wilson's question, are there successful PPPs where which have been successful without any subsidy from the government? Yes, they have been successful without subsidy from the government. Also, when it comes to contribution to the government, my personal belief is that government contribution more towards operations, operational subsidies would lead to more underprivileged members of society to benefit out of PPPs from the affordability angle. So that's one area which can be looked at again, and then the government will decide whether to buy down the capex or to subsidize the OPEX which comes out of. As I said, Nasir, this is a very multi-pronged question. The financing of this, there could be 20 different ways of looking at it. And maybe another session just focusing on the financing of healthcare PPPs could work. But I'll stop here. But I would also like to mention for small-scale PPPs. As I said, the private partners that would be interested for small-scale PPPs might not have the balance sheet to invest into a public hospital. They might not have the balance sheet to get the lending, from banks, and putting all the equity from their pocket might be a no-go there. So definitely for small-scale PPPs, the government, buying down the capex in a way or giving more comfort to private sector will increase the number of small-scale PPPs that can be done out there. Or there'll be more private sector willing to come in and provide services.
Well, that's some very useful pointers there. Thank you, Dr. Deval. Ghazi, would you like to comment some more on the same topic? You're muted. Happens.
Sorry. Yeah. I just wanted to add that in some cases also the government program intervenes for the way that how the projects can be financed or paid. I can give an example of our country that it was a government program that was promising that the healthcare system or the health system will be free in the country. So this is very significant when it comes to the project implementation, because you have to somehow stick to that program, isn't it? In this case, we managed to fund all the projects from the government in the form of availability-based payment projects. So this is our experience in this case, and I think they were successful. I can say about the dialysis center and also for the labs, which was already successful, as I mentioned during my speech before. So this was our experience in funding projects.
That's thank you for that. I think in that sense, the whole kind of integration of this, on the one hand, the financing, the hybrid financing, the co-financing, and so on. On the other hand, the ecosystem, and there was a question also about who will create the ecosystem. Quite an interesting question. I'd like to hear the panelists' views.
Nasser, if I may, sorry to interrupt you, but you may not have seen messages, but we were wondering if Lamine Lo from Senegal could, you know.
Oh no, I haven't seen.
Yeah, I apologize, but since
Oh,
we're
hi. Yes,
we're
of
running
course.
out of time.
I've just seen them.
Yeah. So
Yes, please come in. You're welcome, Lamine.
Thank you, Nasser, and sorry for coming and stepping in, because I was just here to follow and appreciate, all valuable, knowledge that your invitees are sharing. Really, thanks for organizing this, and Ziad, it's a big pleasure just to add few words to echo what previous panelists made in the context of Africa. And I was sharing just as an example to address, this challenge of small scale PPP when we were with the support of the World Bank and PPIF reviewing, the new PPP law, which is the bill 2021 in Senegal. I was at that time head of PPP unit. We added a new mechanism, which is a programmatic approach, which is called it Accord program. This allow in a single process, to have to aggregate small scale project, which will be having, different or one sub PPP contractor, but this allow to launch one process to address several needs which are small scale. So it has to be tested in particular in the context of the health. But what I can tell you, our first PPP contract, which was 13, vocational training, so it's an availability payment, was really under this scheme. Because without that, we would not be doing, because you have 13 areas and just small vocational training in the context of each region that the government wanted to achieve. So in word, basically, it is more easier. It's under government PPP, and it can be aggregated if it's a similar project, meaning you can start with a pilot and project to join at each stage when certain criteria are set. And we allow as well on the government side, because it's mainly set for municipality, that several municipality can be join an agreement, have one which is a quantity for the private sector. So that's what I wanted to add. So thank you for allowing this useful discussion, in particular what's happening. And I remember when we were looking at on the health sector, we were happy to see, for example, in our benchmarking in Brazil, that there were several PPP, which is small scale, at each remote area. That's something that Senegal is aiming. So thank you, Nasser and Ziad and all panelists, and sorry for jumping in.
No problem.
No, not at all. Thank you for that intervention. And I just took the opportunity to look at messages. It's great to have such a widespread audience. I'm seeing Brazil, Togo, Canada, Paris, many countries joining in. So delighted to have that, and hopefully we'll have even more of a international audience as we move forward with this. Okay, how are we doing with time? We have about
if we can have some closing remarks by everybody, and I just wanted to tell Lamine before he goes that we'd like to, please get in touch with us, because we'd like to know more for the sake of this program about the experience of the program that you have in Senegal and the legislation. It not only for the health sector, for everything, it can be very useful. So please do get in touch with us. I apologize for interrupting, Nasser.
No, not at all. This was very worthwhile. Thank you. Thank you for, because I was looking at the Q&As, not the messages. Okay. Yes, we have a few more minutes. So just really a minute each for some closing remarks from each of the panelists. And let's just start in the same order. Arun.
Thank you. Thank you, Nasser. So I think, from my side, health is one of the priority sectors. After COVID, what we have seen in Africa is there is a lot of, sensitization of healthcare infrastructure in Africa. And we have seen that the different partners also are coming closer, together to build the healthcare infrastructure and healthcare ecosystem. And we are part of that, and we are happy to work with all the development partners, private sector who are developing projects, PPP or even private projects also in Africa. And, we are here to support those projects, whatever way possible, even grant or maybe senior debt or credit enhancement instruments. Thank you.
Great, thanks. Dr. Deval?
Hi, Nasir. Yes, I mean, one message to all the attendees is, we always talk about international best practices, but when it comes to social sector projects, we have to take that with a pinch of salt, because social sector has a lot of cultural elements also involved out there, and some local realities. So, we need to look at international best practice, and we need to tailor them to the local situation when implementing any PPP in health sector. But I mean, one very classical example is most of the health sector PPPs, even at a large scale that you see globally, are infrastructure focused, and that was one of your questions also. But where these have been successful are the countries which are developed and they do not have an issue with manpower or capacity to manage these big hospitals. Whereas most of the participants, if I look at the background in the countries, there are issues regarding, say, manpower shortages or management of hospital issues also. Again, if I try to give perspective of it, the number of doctors or physicians in the UK, which has done most of the healthcare infra PPPs, is about 3.2 doctors per 1,000 population. And so you build infrastructure, that is the problem that needs to be solved in the UK, because they have the manpower and they have the management capability. But come to any other country, come to Indonesia, and the number of doctors per 1,000 population is about 0.6, which means that UK has 5 times more doctors per 1,000 population than Indonesia. And so the problem in Indonesia, of course, is infrastructure, but the bigger problem for them is how to get that manpower to run those systems. So that's why the kind of PPP which would be more relevant for a country like Indonesia or any other would be more service oriented. This applies similarly to small scale PPPs also, to look at services. So overall, just a general message that when you're looking at healthcare PPPs, we need to focus on what is the real problem that we are trying to solve. This platform was really great, and congratulations to Ziad and Nasser, Rupa. I think there should be many more discussions like this. It's a real good platform for sharing and exchanging knowledge. So thank you, everyone.
Very much for that, Dr. Deval. Varun and Ghazi, please, like 30 seconds each, just by some closing remarks. Go ahead, Ghazi.
Yes, I would like just to as a closing remarks, I would like to emphasize 2 outcomes, which is that definitely the small scale PPPs can be served as filling the gaps of the bigger projects and filling all the needs that the big project cannot fulfill. And then it is very important the expertise from the outside of the program should be hired, because they bring value to the project and they bring expertise from the other countries or other projects. So this is 2 important things that should be kept in mind. Thank you very much.
Good tips. Thank you. Thank you. And last but not least, Dr. Varun.
No, I just have 2 things to say. One is that, as Dr. Deval mentioned, we are talking about small scale PPPs, and it should be demand driven. And health is a very state specific or very localized subject, and it all depends upon the economics of that area, the disease burden of that area. So it should be generated based on the demand, and also there should be a very strong governance system at the local level as well as at the state level, at the national level, specifically for health sector, because there are a lot of PSP or PPP, whatever, but then we should have a strong governance system, I think, to manage these PPPs. Yeah.
Super.
Thank you.
Okay. This really has been a great panel. I've picked up so much knowledge and so many useful pointers. So I really want to thank you, each and everyone. Rupa, a great organization. Thank you very much. Ziad, thank you for your leadership in WAP. And over to you to close. You're muted.
Yeah, thank you very much, Nasser. It has been a very enriching panel indeed. Thank you, guys, all of you. Nasser, great moderation, really appreciate it. And invite everybody to stay on as the panelists after we end this session for a debrief. And for everybody, for all participants, attendees here, please join us 2 weeks from now, Friday, July 19th, for the discussion session on small-scale PPPs in the education sector. Thank you very much for your support.